almost all patients with SLE do develop some level of lupus nephritis during their clinical course. But 50% of these patients do have a clinically significant involvement of their kidney. And whenever this disease happens, it does entail a very high burden on the patient. So 10% of patients who develop lupus nephritis do develop dialysis down the line in their clinical course. And the diagnosis of lupus nephritis is associated with the increased mortality. As far as the ethnicity and population distribution, we know that depending on the ethnicity, the lupus nephritis can be more severe. And also, the incidence of involvement of the kidney is much higher in patients of African American ancestry, Hispanic, and Asian. Patients who have systemic lupus erythematosus, in a majority of the cases, they do develop some level of lupus nephritis, either on the lab work or clinically. In 50% of patients, we do have a clinical manifestation of lupus nephritis in these patients who have SLE. We do have variation depending on ethnicity, with Black, Hispanic, and Asian having a high incidence of lupus nephritis. Up to 50% of these patients do develop lupus nephritis versus patients who have white ethnicity. Usually in a quarter of these patients, we do see some signs of lupus nephritis. As far as the long-term clinical impact of lupus nephritis, it is a disease with a high morbidity and even does include some increase of mortality in these patients. So up to 10% of patients who develop lupus nephritis down the line do develop end-stage renal disease where they require renal replacement therapy, including dialysis and transplantation. The majority of patients who have systemic lupus erythematosus do develop lupus nephritis, but we do have a variation depending on ethnicity, with Black, Hispanic, and Asian do develop a higher incidence of lupus nephritis than patients of white ethnicity. And as far as age distribution, since lupus nephritis occur early in the course of lupus erythematosus, a lot of patients are quite young in general, and it does disproportionately affect female with an incidence or with a ratio of 9:1 between female and male. Lupus nephritis disease burden is quite high. We know that these patients, when they have systemic lupus erythematosus, usually they do have arthritis involvement or skin involvement or other involvement, which do include increased morbidity from involvement of these other organs. But when we start having lupus nephritis, it does come with an exponential increase in the morbidity where these patients can develop down the line end-stage renal disease requiring dialysis or transplantation. And lupus nephritis also does increase the mortality of these patients. Currently, for lupus nephritis, we do not have any specific biomarkers. We are utilizing currently the biomarker that are general for any kind of kidney involvement. So we're using creatinine and urine protein creatinine ratio, or measurement of the proteinuria in the urine. There is tons of biomarkers that are currently being evaluated in lab settings, but these biomarkers are not usually utilized routinely in clinical practice. So currently what we use in clinical practice are the biomarker for kidney function creatinine, urine protein creatinine ratio, urine albumin creatinine ratio, or 24-hour urine proteinuria, in addition to the usual biomarker for systemic lupus erythematosus, which are complement level C3, C4, CH50, or ANA, or anti-double-stranded DNA. It is common to check creatinine and urinalysis on routine basis as form of screening for these patients. So these patients do receive these screening tests usually on routine basis every 3 to 6 months. And these biomarkers, which are the creatinine and the proteinuria or the hematuria, are used for early detection of lupus involvement or kidney involvement with lupus nephritis.